Greetings, dear learners. We were learning metallic poisons. Under that, we finished learning all the aspects of arsenic poisoning. Today, we shall learn lead poisoning. Lead was one of the first metal known to human and has been widely used during the last 2000 years for domestic, industrial, and therapeutic purposes. Lead-based ochre paints were used approximately 40,000 BC. The toxic effect of lead has been recognized more than 2000 years. Symptoms of lead poisoning have been described by Nicander of Colophon in 2nd century BC, a Greek physician. The ancient Romans sweetened their wine with sapa, a sugar syrup, which contained lead acetate. It is conjectured that it ultimately led to the entire nation suffering from chronic lead poisoning. Consequent lethargy, impotence, and sterility led to the downfall of mighty Roman Empire. With the invention of cars in modern times, a frantic search began for a fuel additive that would improve the engine performance and reduce the engine knock. In December 1921, it was reported that tetraethyl lead could reduce engine knock, so it started to be used as anti-knocking agent. Held as the savior of the American automobile industry, lead tetraethyl began to be added to petrol. Soon, workers engaged in the production began falling sick and several died. Campaigns soon started against the lead tetraethyl and it was withdrawal from addition to the petrol. And now the petrol that is supplied is not containing tetraethyl lead, that is de-leaded petrol we are using. Lead is the commonest metal involved in chronic poisoning. Lead is abundant in soil, being distributed throughout the Earth's crust. Elemental lead exists as a highly lustrous, heavy, silvery gray metal with a cubic crystal structure that assumes a bluish tint as it tarnishes in the air. It is quite soft and malleable. Several of its salts occur as variously colored powders or liquids and are used widely in industry and at home, producing cumulative toxicity on chronic exposure. Lead acetate, that is sugar of lead, has been used in therapeutics. Lead carbonate, white lead, is still used in paints. Lead oxide, litharge, is essential for glazing of pottery and enamel ware. Tetraethyl lead is mixed with petrol as an anti-knock to prevent detonation in internal combustion engines. Among cosmetics, lead tetroxide is most common compound in vermilion, that is sindoor, that is applied by the married Hindu women to the partition on their scalp hair, while lead sulfide is used as collyrium, that is surma, for the eyes, mostly among the Muslims. Lead is used in construction of buildings, bullets, ceramics, electric cable insulations, fusible alloys, hair dyes, lead acid batteries, pewter, potteries, radiation shieldings, shots, shoulders, and weights. Lead and its salt are potent poisons. Various sources of lead exposure could be environmental, domestic, and the occupational. In the domestic sources, automobile exhaust, drug abuse, that is glue sniffing, soil, water could be source of the lead poisoning. In the domestic uses, ceramic beer, colored picture books, contaminated floor, cosmetics, health foods, house paint, indigenous medicines, pencils, toys, and then in occupational, auto repair works, battery making, glass manufacture, mining, plastic manufacturing, plumbing, pottery, printing, rubber industry, shipbuilding or shipbreaking, smelting or refining, electronic soldering, steel welding and cutting are all the industries that are having the use of lead and can lead to the lead toxicity among their workers. Usual fatal dose is not really relevant to lead since acute poisoning with lead is very rare. The average lethal dose is said to be 10 gram per 70 kg of a man for most lead salts, while it is 100 milligram per kg for the tetraethyl lead. However, some lead salts can be potentially lethal at doses as low as 0.5 grams. Children absorb considerably more ingested lead than the adults and are thus at a greater risk of developing toxicity. Toxicity is also enhanced by iron and calcium deficiency. As per the OSHA workplace guidelines, the permissible exposure limit for inorganic lead dust and fumes is 50 microgram per meter cube as an 8-hour time weighted average. Concentration of 100 milligram per meter cube or more are considered immediately dangerous to life or health. Concentrations of lead more than 100 milligram per meter cube or more are considered immediately dangerous to life and health of humans. Lead is absorbed through all the portals of the entry. Occupational exposure results mainly from the inhalation. Tetraethyl lead can be absorbed rapidly through intact skin. Following absorption, it is stored in bones as phosphate and carbonate. In children, about 70% of total body lead is skeletal, while in adult, over 95% is in osseous tissues. Lead is drawn to those areas of skeleton which are growing most rapidly. These include the radius, tibia, and the femur, which are the most metabolically active. The hypermineralization is reflected in the form of densities which are the classic lead lines observed on X-rays. The hypermineralization is reflected in the form of densities which are the classic red lines observed on the X-rays. As you can see here in the picture of the knee joint, the hyperdensity at the junction of the metaphysis and the epiphysis is the lead line basically. And the width of the lead line is related to the duration of the exposure. Significant amounts of skeletal lead are released from bone into bloodstream, periodically resulting in symptoms of toxicity. The conditions favoring this include the acidosis, fevers, alcoholic intake, and even the exposure to the sunlight. Absorbed lead, which is not retained in the body, is excreted primarily in the urine, about 65%, and in bile, about 35%. Regarding mechanism of action, lead combines with sulfhydryl enzyme, leading to their dysfunction. It decreases heme synthesis by inactivating the enzymes involved, such as aminolevulinic acid dehydratase, aminolevulinic acid synthetase, corpoporphyrin oxidase or decarboxylase, and ferrochelatase. This results in anemia. It increases hemolysis, as a result of which immature red cells are released into the circulation, such as reticulocytes and basophilic stippled cell. The results of aggregation of ribonucleic acid due to inhibition of enzyme pyrimidine 5 nucleotidase, which normally eliminates the degraded RNAs in the CNS. Lead causes edema and has a direct cytotoxic effect, leading to decreased nerve conduction, increased psychomotor activity, lower IQ, and behavioral learning disorders. Children are especially susceptible. The highest brain concentrations of lead are found in hippocampus, cerebellum, cerebral cortex, and medulla. Lead also has deleterious effects on the CVS, causing hypertension and the myocarditis. In the renal system, it causes nephritis, and reproductive systems, it leads to infertility. Acute intoxication with lead causes hematuria, aminoaciduria, glycosuria, and hyperphosphatemia, that is termed as Fanconi's syndrome. Lead nephropathy after the chronic lead exposure is a well-known phenomenon. Interstitial nephritis, reduced glomerular filtration rate, and proximal tubular dysfunction are typical findings of the renal damages. In addition, lead can decrease the uric acid renal excretion, thereby raising the blood urate levels and predisposing to the gout, that is termed as the Saturine gout. Then elevated urinary levels of N-acetyl 3D glucosamides, then elevated urine levels of N-acetyl 3D glucosaminidase and beta-2 microglobulin may serve as an early markers of renal injury. Lead basically causes its effect by inhibition of the heme synthesis, that is done by inhibition of the various enzymes that are involved in the heme synthesis, that is the ELA synthetase, ELA dehydrogenase, corpoporphyrinogen oxidase and the ferrochelatase. As you can see here in the picture, that mitochondria, glycine and succinyl CoA combines to form the ELA, and that goes into cytosol. There it is converted with the help of ELA dehydrogenase to the propylenogen, and that is converted to the uropyrinogen, and that to the corpopyrinogen, and that is converted into the coproporphyrinogen, and with the corpoporphyrinogen oxidase, this is converted to the protoporphyrin 9, and again this protoporphyrin 9 may get converted to the cytochrome C with the help of iron and to the heme with the help of the ferrochelatase. So the lead acts on these various sites and inhibits these enzymes, leading to the inhibition of the formation of the heme. Further, the protoporphyrin 9 is also inhibited for its formation from iron by directly inhibiting at the enzymes. Then heme is converted to the bilirubin, that is also inhibited by the lead, causing the inhibition of the heme oxidase in the microsomes. In this way, the effects of the lead poisoning are seen. Then coming to the clinical features of the lead poisoning. Although the acute poisoning with the lead is a rare phenomenon, however, symptoms produced in case of lead poisoning are metallic in taste, abdominal pain, constipation, diarrhea, vomiting, hyperactivity, lethargy, ataxia, behavioral change, convulsions, and even may be fatal to death of the person in case of acute poisoning. Then the chronic poisoning, also known as Plumbism or Saturnism, usually in case of children, it causes the weight loss, weakness and the anemia. The first sign in children may be the subtle neurobehavioral deficit, adversely affecting the classroom behavior and social interaction. Mild toxicity, that is blood concentration of about 40 to 60 microgram per 100 liter, will produce the myalgia, paresthesia, fatigue, irritability and abdominal discomfort. As the concentration of the lead in the blood increases, that is a moderate toxicity, 60 to 100 microgram per 100 ml, it causes arthralgia, especially nocturnal arthralgia, then muscular exhaustibility, tremor, headache, diffuse abdominal pain, anorexia, metallic taste, vomiting, constipation, weight loss, hypertension may be seen in the case of the adults. Then on the severe toxicity, that is blood concentration more than 100 microgram per 100 milliliter, it causes lead palsy, that is wrist and the foot drop, a bluish black lead lines on the gums, that is called Burtonian line. As you can see in the picture, this blackish bluish line above the teeth is the Burtonian lines on the gums. This is seen in the chronic lead poisoning. Then lead colic, intermittent severe abdominal cramps, there may be tenderness around the umbilicus. Lead encephalopathy is the another feature. It is more common in children and is often associated with organic lead toxicity, especially tetraethyl lead, which is lipid soluble and is distributed widely in the lipophilic tissues such as the brain. Tetraethyl lead is metabolized to triethyl lead, which is the major toxic compound. There is sudden onset of vomiting, irritability, headache, ataxia, vertigo, convulsions, psychotic manifestations, coma and death. Mortality rate is around 25%. Even if recovery occurs, there is often permanent brain damage manifesting as mental retardation, cerebral palsy, optic neuropathy, hyperkinesis and the periodic convulsions. Facial pallor, especially the circumoral pallor, is said to be the characteristic feature of the chronic lead poisoning, and this is due to the vasospasm, although anemia may be the exacerbating features of this perioral facial pallor. The anemia that is encountered in plumbism is similar to that due to iron deficiency. It is hypochromic and microcytic in type, but anemia due to iron poisoning is neither associated with reticulocytosis nor are the basophilic stippled cell is seen. Lead is transferred well across the placenta. It can affect the reproduction in males and females and affect the neurodevelopmental milestones in children with both prenatal and the postnatal exposure. Lead may decrease the gestation time at maternal blood level lower than 25 microgram per 100 ml. At maternal blood lead level greater than 15 microgram per 100 ml, there may be the modest risk of intrauterine growth retardations. Lead poisoning during pregnancy has been associated with prematurity, low birth weight and impaired fetal growth. Then in case of poisoning with organic lead, particularly the tetraethyl lead, toxicity are usually non-specific initially and include insomnia, emotional instability, nausea, vomiting and anorexia. There may be the tremor and increased deep tendon reflexes. In more severe cases, these symptoms progress to encephalopathy with delusions, hallucinations and hyperactivity, which may resolve or deteriorate to coma and occasionally death. Severe cases may also develop hepatic and renal injury. It is important to note that in contrast to inorganic lead poisoning, patients with significant organic lead toxicity do not consistently manifest hematological abnormalities or elevations of heme synthesis pathway biomarkers. This is the important difference between organic and inorganic lead poisoning. Then to remember the features of the chronic lead poisoning, we may remember through a mnemonic A, B, C, D, E, F, G, H. A is for anemia, B is basophilic stippling. As you can see here in the picture, basophils are increased and the Bartonian lines on the gums. C for the colicky, D for the drop, that is wrist drop or the foot drop may be there. Then dotted retina in maybe the findings. E for encephalopathy, F for facial pallor, G for growth retardation, H for hyperuricemia and the hypertension. Then to make the diagnosis of the lead poisoning, a proper history from the patient and the relatives shall be taken about the environmental or other source of the exposure of the lead. Clinical manifestations of the lead poisoning should be noted as we discussed. Then the laboratory tests shall include mainly three things: the picture of the blood, urine and the bone. In the blood, various parameters shall be noted, various enzyme markers and the various products are elevated. In the blood, the complete blood count and peripheral smear will indicate the anemia, leukocytosis. Then free erythrocyte protoporphyrin and zinc protoporphyrin levels more than 50 microgram per 100 ml. Blood lead level more than 20 microgram per 100 ml are indicative of the chronic lead poisoning. In the blood test, the delta amino levulinic acid is increased. Coproporphyrin and the protoporphyrin 9 levels are increased. Although the blood increase level are not so useful in the chronic poisoning because the lead migrates in the bony compartments. In the urine, there is the increased concentration of the delta amino levulinic acid, coproporphyrin, protoporphyrin 9, and urine lead level is more than 100 microgram per liter. Calcium disodium EDTA mobilization test may help to diagnose the lead poisoning. However, in case of renal damage, lead may not be secreted at all in the urine, so this may be negative in those cases. In those cases, the bone examination is very helpful. Here, the abdominal X-ray may reveal the lead paint chips or other ingested lead foreign materials. Then X-ray fluorescence estimates the blood lead level and thus indirectly measures the exposure of the lead to the body. Then X-ray fluorescence estimates the bone lead level and is thus indirectly a measure of the body lead exposure. X-ray fluorescence is the emission of characteristic secondary X-ray from a material that has been excited by the bombarding with a high energy X-rays. The principle is exactly same as that of the scanning electron microscope used to estimate the lead on the hands of the firearm shooters. So, in this way, the X-ray fluorescence can help to estimate the bone lead level or the lead level in the human seminal plasma. Normally, human seminal plasma contains about 31 microgram of the lead. However, if it is higher, then it is suggestive of the chronic poisoning with the lead. Usually, it is more than double in case of the chronic lead poisoning. Then erythrocyte protoporphyrin, it was used as a screening tool in the past, but it is no longer considered sufficiently sensitive, still useful as a secondary diagnostic tool for tracking the response to the therapy and distinguishing acute from the chronic lead poisoning, as erythrocyte protoporphyrin level is normal in case of the acute lead poisoning. Then for the treatment of the different conditions of the lead poisoning, we may divide the treatment into the severe acute poisoning with encephalopathy, severe acute poisoning without encephalopathy, then the moderate poisoning, mild poisoning and other supportive measures. For the treatment of the severe acute poisoning with encephalopathy, this is a medical emergency and so appropriate measures shall be taken accordingly. The treatment measures are the British anti-Levishite in a dose of 4 mg per kg immediately shall be given, particularly in children. Then the cranial CT scan shall be done to rule out the cerebral edema. If there is the cerebral edema, it can be managed by following the hyperventilation, maintaining an arterial CO2 tension of the 25 to 30 mmHg. It can reduce the intracranial pressure in patients with rapidly worsening mental status, lateralizing neurological findings or evidence of impending herniations. Prolonged hyperventilation is not desirable in general. Monitor intracranial pressure continuously, monitor cardiovascular function, renal function and serum electrolyte level carefully. Diuretics like mannitol is helpful in decreasing the intracranial pressure. Then glycerol, loop diuretics, furosemide and the ethylphenolic acid may be useful as an adjunct in the treatment of the cerebral edema. Steroids like dexamethasone 16 mg per day in divided doses. Then barbiturates, phenobarbital as a mean dose of 30 mg per kg per day by IV infusion has been used in patients refractory to the other method of treatment of the cerebral edema. In this way, we shall control the cerebral edema and we shall manage the patient. Then the KUV X-ray shall be done to rule out the lead chips in the GI tract. To control the seizures disorder, appropriate measures like intravenous diazepam shall be given. Then the seizures from the lead encephalopathy may be resistant to the anticonvulsant therapy. Barbiturate coma and aggressive control of the intracranial pressure may be needed. Foley's catheterization to monitor the urinary specific gravity, sediments and the lead level shall be done. Calcium sodium ADTA at a dose of 75 mg per kg per day IV infusion is helpful. Reduce the calcium sodium ADTA to 15 mg per kg per day according to the improvement. Then after the initial dose of the British anti-Levishite, repeat the same dose at the 4-hourly interval until the blood levels falls below the 40 microgram per 100 ml. Then reduce the British anti-Levishite to 12 mg per kg per day in the 3 divided doses. Then continue the above regimen until the patient is asymptomatic and can tolerate the oral chelation with D-penicillamine or the DMSA. Then for the management of the severe poisoning without encephalopathy, that is blood level more than the 70 microgram per 100 ml, In that case, British anti-leukocyte in a dose of 12 mg per kg per day and the EDTA in the dose of 50 mg per kg per day is helpful. Discontinue the British anti-leukocyte when the blood lead level falls below the 40 microgram per 100 ml, but continue EDTA for 5 more days. Change to oral chelation subsequently, which may have to be continued until the blood lead level falls below the 15 microgram per 100 ml or 3 months have been completed. In case of moderate poisoning, that is between 45 to 70 microgram per 100 ml, EDTA in a dose of 50 milligram per kg per day shall be given. When the blood lead falls below the 40 microgram per 100 ml, begin the oral chelation. Then in case of mild poisoning, the concentration of lead is 20 to 35 milligram per 100 ml. Then in that case, D-penicillamine in the dose of 30 milligram per kg per day in the 3 divided dose orally shall be given. Start with the 1/4 of the calculated dose, double this after 1 week, double again to full dose after next week. Continue this until the blood levels falls to less than 15 microgram per 100 ml or 3.3 months have been completed. Then in addition to the above measures, the additional measures that are instituted like the injection of the thiamine in a dose of 10 to 15 milligram per kg is said to improve the neurological manifestation of the lead poisoning. In acute poisoning or in event of radioopacities in the gastrointestinal tract on X-ray, stomach wash may be done. Whole bowel irrigation can also be helpful. Lead colic usually respond to the IV calcium gluconate. Correct iron deficiency if it is present. Then blood volumes with the IV fluid shall be maintained. Then if intracranial pressure shall be managed as told earlier. Then in case of the organic lead poisoning, that it is managed symptomatically mainly. Chelation is done only if there is a production of inorganic lead in body from the organic lead. After one round of the chelation therapy, allow an interval of 2 weeks and then estimate the blood level. Repeat the chelation if necessary. Rebounds are common. Some investigators suggest that the addition of antioxidants like lipoic acid, linoleic acid, arachidonic acid in the treatment of lead poisoning as well as in the form of preventive measures against the lead poisoning in person especially exposed to the different sources of lead. And finally, the treatment of heavy metal poisoning is the remove the patient from the exposure. In recent times, a new chelating agent called Suxaimer has been introduced in the management of lead poisoning in Western countries. It is said to be more efficacious and less toxic, so it may be looked upon. Then the treatment guidelines for particularly in the children's, if it is less than 10 micro, then the re-evaluate in 1 year. No additional action is required. If the blood level is 10 to 19 micrograms per 100 ml, then lead education and referral should be provided. Follow up within 2 months. Blood lead level 20 to 40 microgram, then re-evaluate in 1 week. For the blood level 45 to 69 micrograms, then lead education and referral should be provided. Perform clinical evaluation and management within 48 hours. Provide diagnostic testing within 24 to 48 hours. Follow up testing in accordance with the chelation therapy at least once in a month. Then blood level equal or greater than 70 milliequivalent per 100 ml, a medical emergency. The patient shall be hospitalized and begin immediate chelation therapy. In this way, children of lead poisoning shall be managed. Then in case of pregnancy, lead usually freely passes the placental barriers and accumulates in the fetus throughout the pregnancy. Symptomatic pregnant women with elevated blood lead certainly warrant chelation therapy regardless of the concern for the teratogenicity. Postnatally, infant blood lead usually declines over without chelation, though this occurs slowly. Postpartum chelation therapy is warranted for the neonates depending on the blood lead as per the guidelines prescribed for the older children. Usually clinically insignificant lead content is present in breast milk even when maternal blood lead is relatively high. So, allowing mothers with elevated blood lead to breastfeed their infants is not much risk. However, breast milk may be checked for the lead level in very high lead toxicity. Then in case of the occupational exposure, employees whose blood lead level is equal to or greater than 50 microgram per 100 ml should be temporarily removed from the exposure until the blood lead level is at or below the 40 microgram per 100 ml. Then wearing the specialized activated carbon fabric masks may help minimize lead exposure in vulnerable workers. In this way, we may manage the patients of the lead poisoning. Then the cause of death in case of lead poisoning is encephalopathy, failure of the vital functions, liver failure, renal failure, respiratory failure, intercurrent infections and the malnutrition. Postmortem appearance is usually not very specific, but on the gums, Burtonian lines may be seen. In the CNS, the paleness and the greatly swollen, the brain edema may be seen. It is PAS positive, pink staining homogeneous material is seen in the perivascular spaces on microscopy. Peripheral nerve segmental demyelination may be seen. Heart is hypertrophied and the aortic valves are atheromatous. Stomach and intestine may be hemorrhagic and so ulcerative changes. It may be contracted and thickened. And the liver will show the contracted hepatocytes with eosinophilic intranuclear inclusion bodies. In the kidney may be contracted and the proximal tubules may show the inclusion bodies. Fatty generation in the muscles are noted and the hyperplastic erythroblast and the leucoblast in the bone marrow may be seen on the microscopy and in the fat cells, and the lead lines on the X-ray may be seen. In this way, we may have the general idea of the lead toxicity on the postmortem examination, then further confirmation by the viscera and the toxicological analysis from the lab report that will be confirmatory for the lead poisoning. Then certain other medico-legal importance are that it is the abortifacient. It is also used in cattle poison. Then in the donors with the lead poisoning that has the increased seminal plasma lead level have the lower fertility rates than the donors with the no lead poisoning or the low seminal plasma lead level. So for the semen donation purpose also it has to be checked. Then in case of the drug abusers, chronic lead poisoning is sometimes seen along with the other drugs intake. Lead is the contaminant of the manufacture in the cocaine paste. Marijuana, lead is the diluent in the marijuana samples. Employers' liability to the pay compensation in cases of the occupational disease due to the lead poisoning, as we also discussed in case with the arsenic poisoning. Then the pellets and bullets are made up of the leads. On ingestion, suicide has been attempted by ingesting the lead pellets. The concept of souvenir bullet is that the pellets or bullets which remain in the body after the shooting incident, although they don't cause any harm to the body, but on the long run, they may cause the chronic lead poisoning. All the sorts of manner of death by lead poisoning are possible. However, homicides and suicides are rare with the lead poisoning. It is usually accidental. Then we already talked that acute poisoning is rare, whereas usually it is the occupational poisoning. One of the mythological story with the lead poisoning is that the fictional character Dracula suffered from the lead poisoning. In most movies, he shows a bilateral wrist drop and a pale color, both classical symptoms of the lead poisoning. Regarding the source of poisoning, it has been asserted that he may have eaten the lead-based paint coating inside the lining of the casket where he used to sleep during the day. In this way, he got the lead poisoning. This is one of the interesting facts related to the lead. This is all for the lead. Thank you.